I would like to welcome all of you for this IC on SFIOL step-by-step approach. I'll request my co-instructors, Dr. Pramod Bhende sir, Dr. Aditya Kelkar, Dr. Nivian, Dr. Manvi Sindal, and Dr. Mandar to please come on dais. Yes, mine.
Connect at the second top screen. So you can connect there on the internet.
So you can access the podium also.
Okay.
The presentation will be.
One of the presentation.
एक वाला करो सेकंड है नंबर को
I would be starting with the IC. I would like to introduce my co-instructors for the IC. I'm Dr. Manish BAPAYE. I'm from Nasik, Maharashtra. Dr. Pramod Bhende sir, our guru, head of vitreoretinal department, Shankar Netralaya, Chennai. Sir will be presenting on sutured SFIOL. Dr. Sunil will be talking about glued IOL. He is from Davangere, Karnataka. Dr. Manavi Sindal from Arvindaya Hospital, Pondicherry will be speaking on Gabor Chariot technique. Dr. Nivian from Chennai. Dr. Nivian, can you please come on, guys? Dr. Nivian from Chennai will be talking about his patented innovation CMT Flex IOL, which is becoming quite very popular now. Dr. Aditya Kelkar from NIO Pune will be talking about Kanabrava technique, which is a newer technique. And Dr. Mandar Zogolekar, who does Yamane technique extremely well, he will be speaking on that. He's from Kolhapur. I'll be starting my presentation. It is about IOL power calculation in scleral fixated IOL. So SFIL is a popular method of treatment of aphakia, and various techniques are available, and newer techniques are being introduced on continuous basis, and many have already been introduced. The surgeons have large variety of techniques to choose from, and safety and favorable outcomes of all the techniques have been well documented. However, the literature on refractive outcomes is lacking. So there are only 4 papers in English language and 5 total on PubMed search in last 5 years. IOL power calculations are typically carried out for placement of IOL in the capsular bag when we are doing it for cataract surgery using optical biometers. And we VR surgeons tend to assume that the lens will be placed in the same place, whereas in the back position inside the eye. However, we need to look at our data of residual refraction to fine tune our refractive outcomes. These are various parameters which are used by IOL power formulae for calculating the IOL power, like net corneal power, axial length, anterior chamber depth, lens thickness, white to white, CCT, a constant of IOL, and post-operative target refraction. However, in aphakic patient, ACD cannot be determined accurately, and post-op refraction depends on IOL position inside the eye, which can be variable in SFIOL depending on where you are going to implant the IOL. So we decided to look at our data from our hospital, and what we saw, we included patients who had undergone scleral fixated IOL from 1st Jan 2022 to 31st of December 2022. I have done, all surgeries were done by me, and glued IOL using Alcon 3-piece IOL was done. IOL implantation was done 1.5 millimeter posterior to the limbus. Pre-operatively, optical biometry was done using IOL Master 700, and IOL calculation formula used was Barrett Universal 2. The patients who had follow-up more than 3 months were included. There were 44 patients which were identified. However, only 32 could be included as they were filling the inclusion criteria. So there were patients, there were 32 eyes. Out of that, 9 had surgical aphakia. There were patients who had dislocated crystalline lenses or subluxated were 7. Those patients who had dislocated or subluxated IOLs were 10. There were 4 traumatic cataracts. All 4 patients, these were the only 4 patients who had trauma. There were no other patients of trauma in the whole group, and there was a patient of microspherophakia who had undergone surgery in both eyes. So coming to results, the mean spherical equivalent at 1 month was 0.46 with the standard deviation of 1.46 diopters. Median was 0. Mean spherical equivalent at 3 months was 0.23 with standard deviation of 0.9, and a spherical equivalent reduction between 1 to 3 months was not statistically significant. The mean BCVA at 1 month was equivalent to 6/15 Snellen's vision, and at 3 months was 6/10 Snellen's vision. About 30% of the eyes had a spherical equivalent of more than 1 diopter plus or minus, and BCVA improvement from 1 to 3 months was statistically significant, suggesting that with the glued IOL technique, it takes more than 1 month for visual stabilization. Even though the refraction may be stable by 1 month, the vision can still improve. This should help us counsel the patient about delayed visual recovery, and we can tell the patient that there will be improvement as the time passes. Patients with trauma had higher spherical equivalent by 0.3 diopters, minus 0.3. So that it kind of shows that it might be more difficult to do optical biometry in traumatized eyes. So when we reviewed the literature, as I said, there were only 4 papers in English in last 5 years. The first was by IOC2023 et al. In 2021 publication. They had done 14 patients where transconjunctival trocar-assisted 3-piece IOL was implanted 2 millimeters posterior to the limbus. SRK-T formula was used for 22 to 26 millimeters eyes, and Haigis for more than 26 millimeters. And they ended up with, the target was emetropia, however, they ended up with hypermetropic shift. Or et al., who did 20 cases in published literature published in 2020. They did Bausch & Lomb Acryos lens, which was fixated with Gore-Tex suture 3 millimeter posterior to the limbus. They used SRK-T formula and had predicted refraction of minus 1.12, while they achieved minus 0.96, and there was some hyperopic shift as compared to the desired refraction, but SRK-T formula was found to be effective in their studies. This was the third study is a very interesting study by Lee Z et al. In 2021, where they studied SFIOL in pediatric population, where they used Rayner lenses and sutured it with tenoproline suture 2 millimeters posterior to the limbus, and they looked at effectivity of the 5 formulas, that is SRK-T, Holliday, Hoffer-Q, Haigis, and Barrett Universal 2, and they found that SRK-T had a best choice, and there was a myopic shift in these pediatric patients. While Botsford, who had published in Retina in 2019, they used Acryos aqueous lens again using Gore-Tex, and Alcon lens this is a lens which has eyelets in the haptics. So that IOL was used using Gore-Tex suture 3 mm posterior to the limbus, and they also looked at the effectivity of all the formulae. And what they found was that there was myopic shift in their cases, and there was underperformance of Haig's formula, while all other formulas worked fairly well. So Dr. Warren Hill in this online publication has suggested we can make the changes when we want to shift the position of the lens. Depending on the position of the lens, we can change the IOL power, reduce it. And so to conclude, I think when we are doing SF IOLs, very often we are concentrating on technique and doing it right. However, the refraction is not on top of our minds as we are surgeons, but the patient satisfaction depends on uncorrected post-op refraction. So we have to look at IOL power calculation more in depth, and surgeon needs to optimize their results, because there are so many techniques, there are so many types of IOLs which are being used. If you are comfortable with one or two techniques, one needs to kind of look at their results, post-operative results, and optimize the results for particular technique. And distance of IOL implantation from limbus appears to be a very important factor, because that determines the position of IOL inside the eye. I would like to acknowledge Dr. Sunny Sen Gupta from Mumbai, who helped me in analyzing the data. Thank you very much for your kind attention. May I invite Dr. Pramod Bhende sir for his talk on sutured SFI.
Thank you very much, Dr. Maneesh. Good morning, everybody. You have a pointer? Thank you. Yeah, I think it's good to start with the scleral fixation, because that was one of the oldest technique, and now we are moving to other glue IOL or MANEESH technique, or what Nivian has popularized now. So I think it's sequential, let's go with that. So basically the commonest technique what we use is ab externo 4-point fixation. The advantages is enables to deal with the vitreous capsule remnants. Basically, complete vitrectomy is done in all the eyes, remove all the remnants, so that gives a better centration, because you have not having mechanical some tissue shifting the IOL to one side. Infusion cannula, I prefer all these eyes because it helps to maintain intraocular pressure while making proper placement of suture. Limbal, corneal, or scleral marking ensures systemic 180 degree. We'll come to that video presentation slowly. Now, all these patients we all prefer now, as scleral flap. It helps to bail out in case sometime you cannot rotate the eye inside the eye. There is reduced chances of suture exposure erosion in a post-operative period, and there is reduced chances of late onset infection as well. So what we need to learn is the surface anatomy of ciliary sulcus. When you look at it, here you have major arterial circle here, two anterior ciliary artery and long posterior ciliary joining here. You want to avoid this area, and what really you want fixation in a ciliary sulcus, what it means, it is between ciliary processes and back of the iris. This is a space, and this is what your ideal aim is. And where is this space is when you look at it. So approximately when the width is somewhere around 3.39 micron, and you have a distance between surgical limbus, that is blue line you talk about, and ciliary sulcus. It varies. Vertical diameter it is 0.83 millimeter, and horizontal meridian it is around 0.46. So ideal location when you want to place your suture should be somewhere around approximately you take around 0.5 millimeter from the limbus, not 2 or 3 millimeter from the limbus. Then you will land up somewhere here through the ciliary processes, and that is what ideally when you aim for when you really want to in a ciliary sulcus. So yes, IOL with 1 or 2 eyelets on each side are preferred, because there's ease and accurate placement for a suture, and it reduces the chances of slippage or tilt, and you have a foldable IOL lever now. So coming to the step-by-step approach. So as I said, total vitrectomy with the removal of capsular remnants, as you see here, cleaning the area. RK marker I put, you mark the center of the cornea and use RK marker to get a precise 180 degree approach 2 point for fixation. Generally, it's convenient to have a IOL placement haptics in a horizontal meridian fixation sutures. So what I prefer is this is a limbus is marked. Beyond that, we make a scleral flap. So suture distance I aim for 1 millimeter apart, and then we have better coverage. So approximately this flap will be 3 millimeter by 2 millimeter. Partial thickness scleral flap, approximately half the thickness. And because IOL is around 6.5 millimeter with which we are available, so limbal section will be somewhere around 6.5 or even up to 7 millimeter you can go. And once you clean everything, the section is ready. Get this flap ready. You can do even scleral tunnel as well. This is just a technique we used to use previously for 10-0 or 9-0 prorines. So straight needle, both ends. The needle comes out here on both the sides. You can choose whether superior or inferior suture first. But what you need to do is, depending on how you place, the one suture goes from below upwards through the IOL. And when you other suture you put, it goes this way around, because the tilt of the IOL is taken care of when you place this suture. And accordingly, now this is 27 gauge bend needle which I am using to help me out to guide my this 10-0 or 9-0 prolene needle, because sometimes what happens when you pass this needle here, it can get through, you pierce through the one of the some tissue here and get stuck there. So you ensure you have a clear passage. This is out here, and this railroad technique, this needle comes out. And the same technique you follow on other side. You can either pass suture one side, finish and go out, and then other side, or one suture either side and then go back. Either way, it's surgeon's convenience. And this is needle is out. You place the temporary suture here. You need to open the section here. Of course, aphakic eye, obviously you are going to make section now. This eye had a nucleus drop and we have to remove the eye lens and then because hard nucleus and then subsequently. So what happened here is when you place the lens, ensure the suture not entangling, but you guide this leading haptic, you have to guide it in the sulcus. If you allow it to dip, it will get stuck somewhere near ciliary processes. So it has to go precisely in a ciliary sulcus just behind the iris, and then pull this suture on either side. And once you put a temporary knot, close this section first. You have a normal intraocular pressure because eye is hypotonous, collapsing, then obviously placement will not be accurate enough. So before finalizing the suture on either side, you first close the section, then finalize the knot and check the balance on either side and ensure that you rotate the knot inside the eye or through the needle track basically. Now it is easier to rotate through because where 27 gauges needle is used for tracking, that becomes easier to rotate the knot. And at the end, if you want to put the flap, use with a suture, or you want to cover with a glue, it's a surgeon discretion. And this is a standard technique previously used to do, and this is another one. Nowadays we switch to most of us Gore-Tex suture, just short clip here. What I prefer nowadays, because the needle is big one, curved, you don't get straight needles. I use instead of this, other part is okay, but directly I put 225 gauge trocars here. So that will help me to hold the suture and pull it back. These are scleral and corneal marking. So ensure this IOL is placed, positioned properly. These are already Gore-Tex put through the like eyelets and cut off the ends. And this is easier using, so all VR surgeon, all of us, we feel more comfortable using this technique. Just hold with the 25 gauge forceps, pull both the sutures out, one after another. Again, while getting suture out, ensure they don't get entangled. Technically is much easier, and because suture is bigger one, easy to handle, and as far as we know, this suture is supposed to be long, lasts much longer than Prolene. Okay, the similar technique is followed in other side. And once you have this suture out, take the cannulas out. Again, put the slip knot here, temporary knot here. Similar knot on other side. Placing the IOL similar way. There's not much change in the technique. Just ensure they don't get loop or entangle around your haptic or in between two sutures. Just guiding the and when you pull this suture, once you are in, this pull itself is dial the IOL in position when it is in a sulcus properly. Don't release the IOL halfway through, because otherwise it sinks down and then it will not go in a sulcus. You have to reposition it later on then. So just go slowly. Hypotony is because of in between I wanted to just switch off the infusion because iris was prolapsing. So ensure that you pull the suture adequately on either side. And when you pull on either side, as you see here, now, and if its IOL is in sulcus properly, even if you do not tie the suture, it will not slip posteriorly, stays there. The only difficulty here is suture being a thick one, it's not that easy to rotate the knot inside the eye. So you really have to sometimes push inside rather than rotating it in. So just cutting off suture. And another practical difficulty, because after cannula system and we have partial thickness flap, sometimes it leaks. So I prefer to use glue to stick those flap back. See here, sometimes you literally have to push this knot inside. So both the knots are rotated, but then suture is like little bit pliable. It becomes flattened and easy to, not that difficult. So that's what ends with and cover with a glue generally I prefer. So to conclude, technically it's relatively difficult and time consuming technique, but it's time tested. Suture SFIL works very nice with a good visual potential. However, there are increased chances of suture breakage with time. We do not know, we do not have long-term experience with Gore-Tex now, but with Prolene, we have almost 15 to 20 years of experience, and quite a few patients we are having a suture snapping and they are coming back. And that's why we are switching now to Gore-Tex IOLs, and new IOL designs are coming, and obviously techniques are evolving, which will be discussed in subsequent talks. I take this opportunity to invite all of you to our next Retina Summit, which is scheduled on 30th June and 1st of July. Thank you very much for patience hearing. Thanks, Maneesh, once again.
That great talk. We'll take the questions in the end so that we don't run short of time. Can I invite Dr. Sunil for his talk on blue eye?
Yeah. Good morning, everyone. Today I'll be talking to you regarding the glued IOLs. The glued IOL is a proven method of intrascleral fixation. It's one of the proven method and provides an optimal results in secondary IOLs. The key to the performing the glued IOL is one need to measure the white to white diameters to gauge the amount of haptics which are available for scleral tucking. The tucking of the haptics in the intrascleral is the most important surgical step to get the stability of the IOL in glued IOLs. The prerequisites are two. Any three-piece IOL, you require preferably foldable IOLs. The other is a tissue glue, which needs to be, you need to have these two things to do a glued IOL. Like in any other secondary IOL, one need to do a corneal endothelial evaluation, pachymetry, look for vitreous in the AC, evaluate the iris, angle, capsular evaluation should be done on the posterior segment evaluation. Like sutured scleral fixated IOL, here also you need to make it ideal optimal sized scleral flaps approximately 180 degree apart. The size of the flap should be optimally around 2.5 to 2.5 mm the width. And you can use the markers, either the toric markers or now glued IOL markers are available for making these scleral flaps. Why the size of the scleral flap should be optimal. Two large flaps, sometimes you may have a lesser amount of haptic, externalized haptic for scleral tucking. If it is too small flap, sometimes you may find it difficult to tuck the haptics into the pocket. The sclerotomy should be made beneath the scleral flaps, and they should be 180-degree apart, so that the marking should be very proper. Improper sclerotomies sometimes can lead to the decentration of the IOL. First I will be telling you the theoretical aspect, then I'll go to the video. The IOL unfolding is the most critical aspect. It should be slow and gradual. The 3-piece IOL should be loaded in such a way that the tip of the haptic, the leading haptic should be outside the cartridge when you enter the AC, so it is easy to grasp the tip of the IOL. Once it is there, then slowly inject it for the maneuverability. Start injecting the IOL inside the anterior chamber once the tip of the haptic is grasped to prevent the IOL drop. So the leading haptic should be grasped properly at the tip. Do not pull the tip of the haptic before the entire IOL unfolds in the eye, so sometimes it can damage the IOL and the haptic. Haptic maneuverability, typically what has been described is by a handshake technique. One should externalize the haptics, but do not hold the IOL at the mid shaft. But if you hold at the mid shaft and pull it, sometimes the haptic can break, or kinking of the haptic can happen. Sometimes you may have to explant the IOL and redo the whole procedure. Anterior vitrectomy, it is very critical for any secondary IOLs. It should be properly, vitreous should not be there at the sclerotomy site as well as in the pupillary area. The haptic tuck, you need to, after creating the flaps, you have to create an intrascleral pockets using either you can use a 26 gauge needle, or you can use a bent MVR blade, 1 blade to create an the one thing you should be careful in these patients is don't make a too thin scleral flaps, because it can expose the haptics once you tuck it into the sclera. Of course, the glue application, the couple of things I would like to say in glue application: keep the area dry before you apply the glue. So switch off the infusion. Either it could be pars plana infusion or your anterior chamber maintain. It has to be shifted on, and air can be put into the anterior chamber. So it keeps the area very dry, and you can put once you tuck the haptics, you can put the glue under the scleral flap and proceed. Even the conjunctiva also can be closed with the clear corneal incision, and conjunctiva both can be covered with the glue. Let me show you a video of the glued IOL, whatever the steps I described now. Key here is the marking of the 180-degree opposite angles, opposite axis, because if any decentration leads to the decentered IOL, so make the optimal size scleral flaps, lift up the scleral flaps. Then approximately around 1.5 mm behind the scleral flap. Either you can, if you're comfortable, use a pars plana infusion, or you can use an anterior chamber maintainer also if someone is not comfortable with the pars plana infusion. Make sure that the cannula is inside the eye. Make a sclerotomy, use a 22 gauge needle. Your direction of the needle should be critical, because you may damage the iris if you go too anteriorly also. Keep the volume of the chamber and the eye very taut, so that it should not be hypotony while doing these maneuvers. Sometimes it can bleed. The preferable to have a 3-piece foldable IOL. Many companies do that. Preferably, many use either Johnson & Johnson or an Alcon 3-piece IOLs. Once you get the leading haptic, the tip is seen. You should, from the sclerotomy, use grasp it and externalize it. Keep slowly injecting the IOL. Don't pull at one go, because you may damage the haptics. So externalize it. By handshake technique, the other haptics also is externalized. Make sure that the first haptic should be held, so that there should not be any snip back of the first haptic which has been externalized. Slowly pull it out. Make an intrascleral pockets now and tuck it into the sclera and apply the glue. tuck it in, switch off the infusion so that the should not be area should be dry. Then apply the glue, close it. So the main concern here is some of the challenges when you face is when the eyes have got a large wide to wide diameter or large eyes, then the limitation imposed by the commercially available IOLs may not fit into this. So you need to do some certain modifications in a large eyes or with a large wide to wide. We call it as a five-pronged approach or a 5 techniques which we can adapt. One is instead of doing an horizontal glued IOL, one can do a vertical glued IOL by sitting on the temporal side. That's the one thing. And you can make a sclerotomy little bit anterior. Typically, you tend to make it around 0.5 millimeter instead of 1.5 millimeters. Sometimes if you do 2 anterior sclerotomy and the glued IOLs, the optic capture incidence is very high. So you may have to do a pupilloplasty to prevent the optic capture because of anterior placement of the IOL. Then where area which you are entering anteriorly, 0.5 mm, that area we can do a peripheral iridectomy to prevent the iris incarceration or creating an iridodialysis in that area. Of course, the fixation of the trocar anterior chamber maintainer helps in these eyes. So the vertical glued IOL, as I told, instead of horizontal 3 and 9, you sit at 6 and 12, you have to do the glued procedure. Anterior sclerotomies, it can made at 0.5 mm, but the one thing is you should not push the needle too hard when you're making anterior sclerotomies at 0.5 mm because it can cause an iridodialysis. There is a vitrector assisted peripheral iridectomy done when you're doing an anterior sclerotomy. Instead of 1.5, if you're going around 0.5 mm, make a small cutter assisted iridectomy in those areas. Small eyes, of course, here the concern is not the externalized haptics will be too lengthy. One may have to trim the haptics to tuck the iris into this haptic into the thing. The pupilloplasty role I told, if it is sometimes there is an optic capture risk, so one need to do a single pass 4-throw pupilloplasty in these patients. We had published this article way back. It's my own article published in JRS in 2012. In this article, basically, I compared the glued IOLs with the sutured IOLs. This study mainly highlights the suture-related complications of the scleral fixated IOL, how it can be overcome by using the glued IOLs. So this is an initial study which is done way back in 2012. So the key steps in glued IOL is one is the handshake technique. The glued IOL technique can be combined with many of the surgical maneuvers like corneal procedures, or it can be used as a scaffold for a dropped nucleus or an intraocular foreign body. There is a less incidence of posterior complications. There is a less chance of pseudophacodonesis in these patients. So intrascleral haptic tucking is the most critical part of it. So IOL related complications, this is a study with one of the studies which shows that it is more with the rigid IOLs than with the foldable IOLs. Even the optic capture, IOL decentration, haptic displacement, subconjunctival haptic extrusion, all these occurs with the rigid IOLs more than the foldable IOLs. These are the complications, both anterior segment and posterior segment complications, starting from glaucoma to ERMs, detachments, all these have been compared in the patients with the glued IOL. Even the second surgery rates are more with the rigid IOLs than the foldable IOLs. So as I told, it can be combined with endothelial keratoplasty procedures because you need an IOL support for most of these procedures for air tamponade. So you can combine glued IOL with the corneal endothelial procedures. Scaffold, of course, definitely is. Thank you for the patient hearing. I would like to say one can adapt the secondary IOL fixation of your choice based on your expertise and skills. Thank you once again.
Thank you, Dr. Sunil. That was very elaborate and excellent presentation. One point I can make is, for making the flaps, Ashwin Agarwal marker is very good, gives very precise measurement for flaps for
definitely, it's a very good tool.
Yeah. Next, I invite Dr. Manavi Sindal for her talk on Gabor Chariot technique, glueless, flapless technique of ISFI. Is there a problem with the presentation?
Okay. So good morning, everybody, and thank you, Manish, for inviting me to be a part of this IC. So I shall be talking about the Gabor-Scariat technique of SFIL. So this was a technique which was pioneered by Gabor-Scariat, where he exteriorizes the haptics of a three-piece IOL, and then these are tucked into scleral tunnel or pockets, and it's one of the techniques of sutureless SFIL. So in this, limbal parallel scleral tunnels are made, as demonstrated in this images here, of about 1.5 to 2 millimeters length. And then a sclerotomy is made at the start of the tunnel, through which the haptic is exteriorized, and then it is either pulled through or tucked into that tunnel. So how do you make these tunnels? You can either make it with a 23 gauge MVR, or you can do it with a bent 24 gauge needle, or with a 1 millimeter side port. Either of these instruments work well enough to make the scleral tunnels on the two sides, or the Gabor's tunnel. So here is one of the videos which demonstrates how this is done. Initially, I used to do a peritomy. I have stopped doing that now, as you'll see in the later videos. And then a marking of the horizontal meridian by the toric IOL marker. About 1.5 to 2 millimeters is measured, and the two tunnels are made, the one on the right side going downwards and the one on the left side coming upwards. This was an anteriorly placed lens, and my anterior segment colleague has removed it from the anterior chamber directly. And so again, to maintain the chamber, it is good to use some kind of a pressured infusion. So in this case, after the nucleus is delivered, an AC maintainer is used, whereas otherwise normally I use a pars plana infusion. A limited anterior vitrectomy is done over here to clear out all the vitreous that is present, which is also very essential not to have any vitreous in place. And after placing this, two sclerotomies, now these are made with 24 gauge needles exactly at the beginning of these Gabor's tunnels. And the DAORC produces these Scariot IOL holding forceps, which come as a pair, a curved and a straight. The curved video has stopped playing. Mm-hmm. I'm not even getting that here to forward it. Okay. So I'm sorry for this error. So just to have a few pointers as we go back through these steps again, it is very important to be sure that you mark your horizontal meridians properly. I think all of us will keep on saying this again and again, because these small points of being meticulous in them are very important to have a good centration of your IOL. So if your horizontal is not proper and you go a little above or below, it will be up superiorly or inferiorly decentered. Similarly, whatever entries, tunnels, whatever suture fixation you make on the two sides from the limbus should be exactly at the equal distance, because this can then cause a tilt also in the IOL. So here, after making these two sclerotomies right at the beginning of these tunnels, and then we go with the curved of the two Gabor-Scariot forceps. Okay, anyways, we'll move ahead. So this is the handshake way of doing it. And then there was a modification to this. We'll see this again in another subsequent video also. So there was a modification of this done by my colleague, Dr. Prabhu, who's sitting right here with us, called the XNIT, or the extraocular needle-guided technique for haptic insertion. So here, when we do this handshake, the problem is you have to take the forceps into the eye, hold the haptic accurately, and bring it out. During this, if you miss holding the tip accurately, you can lead to a slippage of the haptic into the globe and make it more difficult. So this XNIT makes the procedure far more simpler. And the XNIT device is manufactured by Aurolab, and it has a pre-bent 26 gauge needle with a silicone stopper in place and a plastic handle which has a 1.5 millimeter marker also available on it. So this is a video of the XNIT technique. I nowadays do not make complete peritomies anymore. I either make a small limited peritomies in the side or just two slits. So here I'm making the two tunnels on the two sides with the Gabor's, with the 23 gauge MVR. These tunnels should also be very perfectly tangential to the limbus in both the directions. Otherwise, haptic tucking can be difficult. And I usually prefer to do a complete vitrectomy. Following this, a section is made. The XNIT technique is only limited by the fact that at its current version is useful only in rigid IOLs and is not very suitable for PMMA IOLs. So here I'm again verifying where my tunnel exactly lies, and after verifying that, I go in with this 26 gauge bent needle with the silicone stopper. I get it out from the section and thread the haptic of the IOL into it and railroad it out. And now the silicone stopper very efficiently holds the haptic in place, just like Dr. Sunil was also speaking. Instead of having an assistant or somebody with a MacPherson holding it for you, it is now helped over there very safely and strongly and will not slip back into the eye. You can easily now exteriorize your trailing haptic without any concerns or having to bother about what is happening to your leading haptic. So again, this haptic is now threaded into the needle and is exteriorized out of the eye. This is now held. Now here I'm using the forceps which is manufactured by Epsilon or the DOC ones. These are the two ones which are used, and the haptic is tucked in place into the Gabor's tunnels. As you make the sclerotomy for exteriorizing the haptic as close to the tunnel, there is no exposure of the haptic anywhere outside. You can also adjust how much you have tucked the haptics on both sides to get a good centration of the IOL. Since this was a pediatric eye, I am suturing my scleral tunnel and sclerotomies. Here I'm showing how we can fixate in acrylic SFIOL. For acrylic SFIOL, you have to use the handshake technique. And here you see now my peritomy is just a small slit. As you get more experienced and comfortable, and you don't really need to visualize where your tunnel openings lie, it is comfortable enough to have just that minimal, wherein you negate even the need for closing your conjunctiva. And now over here with a clear corneal incision. And this is now the curved DORC forceps, and that is introduced into the eye first. And I use a Sensar 3-piece IOL, and because this has a rotatory type of an injector, my assistant needs to rotate it to inject it out while I hold the leading haptic. And as the IOL is unfolded in the eye gradually, and the trailing haptic is left out of the section. At this point, you can proceed to tuck in your leading haptic at the same point of time, and then go back to your trailing haptic, which is now again fed into the eye, and by handshake technique, being careful again to hold just the tip of the haptic, like Dr. Sunil just said. We then go ahead to tuck this into the tunnel. Following this, I usually just cauterize those two small scleral conjunctival incisions just to close it, and this is a truly sutureless procedure. The same technique can be used to refixate any 3-piece IOL which is dislocated into the eye. So somebody's had a PCR and was previously placed a 3-piece IOL, and if that IOL is now fallen or dislocated or grossly decentered into the eye, we can very much just refixate that eye. So here I have a grossly decentered IOL, which after a vitrectomy then goes into the vitreous cavity completely, and limited base dissection sometimes depending on how much vitreous is left behind. I like to place a small bubble of PFCL just because it makes, and place the IOL on top of that, so it makes grasping that tip of the haptic much more easier, and I'm not going too near the retina, and I'm not worrying about whether I'm touching the retina when I grasp it. And now I enter with the straight of the DOC forceps through the sclerotomy for exteriorizing the haptic, and the light pipe in the other eye, exteriorize the haptic, one of the haptics, and proceed to tuck it in. After one haptic is tucked in, most of the time the second haptic can be just visualized without your 3D visualization system. If it's too deep, you may need the visualization system. And again, you can just fixate the same IOL back in position. You don't really need to remove the IOL if it's a 3-piece IOL. Remember to remove the PFCL bubble in the end. I tend to need my assistant to do that for me. So we have compared our outcomes of sutureless SFIOL with sutured SFIOL in a paper which we published in JCRS in 2016, and we found comparable outcomes in both the two. And we found that this surgical procedure was safe enough in eyes which had aphakia post-trauma as well as post-cataract surgery. I also have published my findings in pediatric cases where we did SFIOL in 45 eyes, out of which 36 of the cases, 80% were sutureless SFIOLs. This was published in European Journal of Ophthalmology in 2021. And these children also did well, and we found that the technique was safe in these pediatric eyes also, with a good visual improvement and a good improvement in the uncorrected visual acuity also. There are some complications with every procedure that we do. One of the important ones here is haptic disinsertion, so which can need haptic retucking. And sometimes in these acrylic IOLs where the 3-piece IOLs, the haptic is kind of very loosely tucked into the optic. So you can actually have separation of the haptic from the optic and not from what you have inserted, and in which case you need an IOL exchange. There can be transient hypotony, and this is more prominent when you use the handshake technique, because the sclerotomy with which you are passing the forceps and exteriorizing is actually unsutured over there. But most of these, you just patch the eye for a day and it resolves off. It's very rare, especially in pediatric eyes where I may need to do a globe reformation. You can have a trickle of vitreous hemorrhage either through the Gabos tunnel or from your manipulation of the haptics. But since I do a complete PPV, it's not of concern. It again resolves off within a couple of days. A CME is seen in our series. We saw it in 13 eyes. That's about 2% of the eyes. And rarely, of course, we can have a retinal detachment. Very, very rarely, we have reported the occurrence of hemorrhagic CD, wherein it can occur if the MVR, which is used to make the Gabor tunnels, inadvertently has gone in very deep. Even these cases actually had good resolution of the hemorrhagic CD with good visual improvement. So again, we have many choices. We have already presented a few, and my esteemed colleagues are going to present a few more. And like a kid in a candy shop who can't choose, but you can choose the best technique which you're comfortable with. Thank you. And I would like to take this opportunity to invite you all to another instruction course today afternoon at 3 p.m. at Turquoise on publication. Thank you very much. Thank you again, Manish.
Next, I would like to invite Dr. Julian, who will be talking about the flex technique, which is his patented IOL, used by our customer, and will be talking about in detail about this.
Thank you, Manish sir. Can you make it full screen?
Okay.
Manish, till then, I think you want to take any question. I think they're setting up. Okay. It's coming? Okay. Sorry for that. So, respected teachers, senior ophthalmologists, my dear friends. So, I'm Dr. Nipin, and I'm going to talk about the new innovation, the CMT Flex IOL, a new option for aphakia. No financial interest in my presentation. As you all know, all inventions come with the question why. So did mine. We have seen here in this particular session that the various types of secondary IOL techniques, starting from the sutured technique, which is still the gold standard, which is tested for more than 4 decades. And then the Gabor-Chariot externalized the haptics, and then various modifications of these externalizations like the glued IOL technique, then the XNIC technique, and then the MANEESH technique. But then thought, why not have a new design of an IOL for this type of aphakic patients? So that gave birth to the CMT Flex IOL, which is nothing but a single piece hydrophilic lens with a T-shaped haptic on either side. So these T-shaped haptics, when brought out of the sclerostomy, opens up and prevents the lens from falling back inside. So let me just go through a couple of surgical case scenarios to explain how it works. So here again you have a case of aphakia which was planned for a secondary IOL. As you all know from all the other previous speakers, 0-180 degree marking is a very, very important step for any secondary IOL. So here we make the 2 by 2.5 partial thickness scleral flaps with a crescent blade, and 1.5 millimeters away from the nimbus, I make a 23 gauge sclerostomy. So being hydrophilic, this lenses is a foldable lens, so it can be done through a clear corneal incision, as you can see here. So as you inject the lens, the T-shaped haptics has to come out first. So it's easy to grab it head on. So you have various parts. The neck can also be held, but ideally this place is easy because when it comes out of the sclerostomy, it actually bends forward. So it has less resistance when it comes out of the sclerostomy side. At this time, do not pull the lens because it's a single piece lens. So inject the remaining lens, leave the trailing haptic over the iris or at the wound. And once the lens is injected, then you slowly pull out and you can see the pop of the T junction and it stays outside there. So just a small animation video clip to show how it works. It can work with any regular IOL cartridge, the foldable lens. So clear corneal incision, just a regular 2.8 millimeter incision, grab the head of it and then pull it out and it stays over the scleral flap. For the other side, we use the handshake technique. So you use specialized forceps called the grasping forceps and hold the arms of these forceps and exchange it to the other side. Being hydrophilic, again, it is less tissue forgiving and damaging, so you can maneuver it very well within the eye, and you can see the second haptic brought out and pops out. So once that is done, there is literally nothing else to be done, and if you get the 0-180 degree, there's not going to be any tilt. So once that is done, you can either glue the flaps or you can suture the flaps or you can even do cautery. This is day 1 post-operative pictures of the lens that you can see here, and this is 1 month post-operative pictures where you can see clear corneas, well centered. We also did studies on UBM and the OCT pictures over the sclera to just see long-term how the flaps and if any exposure of these haptics are going to be there. So then after getting this, we move on. You can actually combine with any challenging cases, like any of the secondary IOLs, like any trauma or any cases can be done. So the second case is one such case. It was a young patient who was on maximum glaucoma medication, long-term injury, aphakia. So it was planned for a trab with a secondary IOL implantation. So first the glaucoma surgeon went ahead and did the trab superiorly, as you can see here. Just going to rush through the video, mitomycin C. Let's see if I can find the PA and the absorbable sutures. So then again, now we make the flaps again 0-180 degrees is again very important here. And then a good anterior vitrectomy. I think for any secondary IOL, the key success is again having a good anterior vitrectomy. Make sure there is no any vitreous. And I always like to stain the vitreous with tricot for 2 reasons. One, you are able to see the vitreous. Second, some amount of the tricot crystals that go underneath prevents some amount of post-operative CME also. So these are the 2 specialized forceps, the grasping forceps, which has got the serrated edges, and the CMT flex forceps. So this thing being, because it's a hydrophilic material, the retina forceps sometimes with the sharp edges, when you hold these lenses, can bite into the material and chip away the material, and that can cause breakage of these lenses. So here again, you can choose a different site for injecting the lens. You can see the T-shaped haptic coming out first. Grab it. Again, just wait. Just inject the remaining of the lens. So once the lens is there inside, out of the cartridge, and then you gently pull it out. So the key here again in doing is, it has got a learning curve for any of these procedures that we have to do. Just make sure you don't lose the grip on it. So here you can see it's there on both the sides. In this particular case, we had the sommering ring also to deal with. So as you all know, these are like calcified remnants of the cataract portion with the capsule, and sometimes it is not very easy to dislodge them or remove them with IA. So in this particular case, it was nice because we used this T-flex as a scaffold here, and just lowering your bottle height, we used the phacoemulsification to eat away the sommering ring, because sometimes we take a long time and struggle if you want to do it with an IA. So just make sure you don't lose any of the pieces behind, because so far everything else is done anteriorly itself. So once the sommering ring is cleared, there was some synechiae also that were there superiorly. This was because of the trauma. So all the synechiae were released. And that is why the pupil looks irregular. If you can see, it's not the decentration of the lens. It is because of the size of the pupil that is irregular, that is giving picture. So once all the synechiae were released, this is how the patient entered on table. This is post-op picture 1 week with a good filtering bleb. You can see the scar on the cornea, the trauma, the PA, and a well-centered IOL. And also for anterior segment surgeons, also it can be done. I always think the biggest challenge is hypotony in any of these cases. So ideally, having an AC maintainer is good, because we are surgeons more comfortable with using a trocar, but we can do it through the anterior approach. So, but the principles again remain the same. This was a case which had an aphakia post small incision cataract surgery. You can see the sutures there, but you don't have to open up the wound. You can go to a fresh site after a good vitrectomy. Again emphasizing the point of having a good vitrectomy in any of these secondary IOL cases. So here advantage, that's why I'm not injecting the lens. So even if you lose the grip, you can always go and re-grasp it again. There's no hurry. Just make sure you feed it into the forceps and then inject the lens. So you had it inside the cartridge, so you don't have to worry about it falling back inside when you're doing this. I usually prefer to hold the flap just to make sure, because there's always a tug there at the sclerostomy side because of these forceps, because these are 23 gauge forceps, and then it comes out. So others say the same thing. I'm just going to So at the end of this particular case, I just use trichot to check in the anterior chamber if there's any vitreous left. As you can see, so there's no harm in always checking to make sure everything is fine, and then using the glue. So there are complications related to this, like you can have the breakage of the haptics or slipping when you pull the other side, late dislocations, exposure under the sclera. But I think some of these complications are common for all secondary ULs, and there is a learning curve. So it took a long journey of more than 6 years from the drawing board. And now I'm happy that more than 250 users across India have used it and also given their feedbacks about modifying the techniques. And these are some of the publications that we have in the various journals. And yes, maybe because of COVID there was a delay in everything, so hopefully everything works out well, and this is our painted. So once again, thanks AOS, and a special thanks to Dr. Manish sir for having me here in this session on secondary IOLs. Thank you.
Congratulations on your patented technique, Dr. Nivian. Next, we will have Dr. Aditya Kelkar from Pune talking about Canabrava technique of SFIL.
So first of all, let me thank Dr. Manish for having me in this instruction course, which obviously seems to be one of the most popular courses here, looking at the attendance. So probably you have the pulse of the audience. So I'll be talking about the Canabrava's technique of IOL. The reason why these techniques are going back to sutures again, can I have my slide please? Is probably because the haptics that we externalize and tuck them in the sclera is not really physiological, although the position of the lens may be physiological in the sulcus, but the haptics are supposed to lie inside the eye, and that's why we are going back probably to the sutures or the technique that Dr. Nivian has beautifully demonstrated. So as you know that post-cataract surgery aphakia is less than 1%, but a lot of morbidity for patients as such, and we all have to deal with these situations. So I'm sure all of us are here to learn about what all the techniques exist for managing the aphakia.
Dr. Aditya, just hold on. The slides are not.
Yeah.
Yeah.
No. So Canabrava's technique basically has a principle where they use a 5-0 proline so as to have a flange into the haptic if we are using a PMMA IOL, and the other flange comes under the sclera. Or if you are using a lens which is like Envista IOL, you can loop it around the IOL and have both the flanges outside the sclera. Yeah, my screen shows a different slide from that one.
Yes, come now.
Yeah, but this is already 2 slides ahead. Use that one.
Use that
Come here. It is here. You come here.
Right. Okay, so there are various scleral fixated IOL techniques, the XNIC technique by Dr. Prabhu and Geber Shariats and Narang Yamane, lots of options we have. And we have also studied a couple of surgical techniques. I also compared the scleral fixated IOL with the iris claw IOL, and we found not much of a difference. Although ovalization of pupil is an issue with iris claw IOL, although it's one of the most easiest techniques to perform. So with all this, probably SF IOLs obviously are not free of complications, posterior dislocation, decentration, haptic related complications, subluxation, everything is there like in any other case. And just because we want the haptics also to lie inside the eye, probably we have again come with a circle of life going towards sutures. So as I said, Canabrava's technique initially evolved from fixing the Sionis capsular detection ring using 5-0 proline by a flange technique, and the combination of the needle described by Yamane's technique makes it very interesting. So you can use it with the foldable IOL, or you can use it even non-foldable IOL, and of course you can have an option of even fixing a toric intraocular lens such as Envista toric IOL into the axis of our interest. So this is a technique where again a Johnson & Johnson Acryos IOL has been used, and a scleral tunnel has been made first of all to ensure that the lens can be placed in the eye. Then I have my conjunctival peritomy, and I use these 4 trocars to externalize the sutures. This is not exactly what has been described by Dr. Canabrava, but this is the technique which I first learned before going on to learning the Canabrava's IOL. So pass this loop through this Acryos IOL, one on either side. This is the 6-0 proline that I'm using, and then just pull those 4 ends out, and you can tie a knot like how Dr. Bhendisar has just shown us using the Gore-Tex suture. So this is how I started my journey of learning Canabrava's technique, and then going on we started doing it for the Envista IOL. This is one of my first cases, although you can use a limbal incision to introduce the IOL in the eye by injector system. However, I was beginning with this, so ensured that I have a good scleral tunnel. Anterior vitrectomy was done, and then going 2 millimeters and 2.5 millimeters behind the limbus, I made 2 dots there on the sclera and pass a loop through the eyelet in the optic haptic junction of this Envista IOL. First get the first thread out, this one comes 2.5 millimeters behind. Then I go again 2 millimeters, just 5.5 millimeters ahead of the previous mark, and get the second suture also out, and the same procedure is being followed on the other side. So it's basically a 4-point fixation, but all the 4 points are now in the sclera under the conjunctiva. And then you push the lens in the eye and just pull both the ends on either side, and the lens gets centered. Cut these and the centration is quite good because you have these 4 sutures to manipulate your positioning of the IOL. Coming to another situation where this patient presented with traumatic aniridia and I wanted to fix this aniridia IOL. So the 4-point fixation is done in a different way here. The first suture is flanged outside, and then the other end of the suture is cut flange inside the eyelet of the IOL. This eyelet in the aphakia, the IOL is at the haptic, so you flange that on either side, and then once again put those sutures to position the eye so that it's well centered. So you already have these 2 suture ends outside the sclera. That you need to do is put those 2 ends and position the lens in the eye. This lens, if you want to do with external haptic fixation, then you have to break those eyelets which are there onto the haptic. So this technique, especially in aniridia cases, works best with Canabrava's technique because the haptic is now made on the lens and you don't have to cut the eyelets. So again, a well-centered IOL. That's the beauty of this technique. So I thank you once again, and I think we probably will have the discussion at the end of the talks. Yeah, thank you.
Thank you, Dr. Aditya. That was excellent presentation with different types of IOLs used and different types of fixations done with proline suture. Now I invite Dr. Mandar Zogolekar from Kolhapur. He will be talking about Yamane technique and tell us about various making it easy for us.
So I'll be presenting the classical Yamane double needle technique, which was described by Dr. Yamane. So no financial interest. So it's a glueless and sutureless technique. Complete vitrectomy and removal of capsule is mandatory, as most of the speakers have already told. So this firstly, we insert a needle, 27 gauge or 30 gauge needle as described by Yamane, Dr. Yamane, and we thread the haptic inside the bore of the needle. Then another needle is inserted 180 degree apart, and the second trailing haptic is inserted inside the bore of the needle. Then they are externalized by pulling the needles outside, and heat applied to create a flange so that they don't go inside, and they are tucked inside, and there ends the surgery. So important thing is to mark the axis. So horizontal axis should be perpendicular, almost 90 degree to the wound, so that you can easily grasp the haptics easily. Then you have to make 2 millimeter mark from the limbus, another 2 millimeter marks in a clockwise direction, which has to be around 10 degree angulation to the parallel to the limbus. This is to accommodate the haptic angulation so that it doesn't tilt post-operatively. The same thing is done on the other side. So we insert a needle through the sclera from point A to point B, so that there is a path of intrascleral path of haptic is created, and not just one point fixation. The IOL is injected inside. In this case, it's a foldable IOL. We use a vitreoretinal forceps. I prefer a max grip forceps to tuck it inside the bore of the haptic. You have to be very gentle with it so that you don't bend it. If you bend it, the final position of the haptic will be, of the IOL will be compromised. Next, another second needle is inserted. Again, a 2 millimeter tunnel is made while inserting. The trailing haptic inserted in the bore. This can be tricky, but with experience you can do it easily, because you are using a non-dominant hand, so that's the problem many of times. Both are externalized by pulling simultaneously, and we apply heat cautery to deform the ends. This is and we then push it inside and tuck them inside the tunnels we have created. And that is the end of the surgery. No suture, nothing is required. So why 2 needles? If you just pull, some people advocate using one needle first for the leading haptic, take the same needle on the opposite side after creating flange. But if you do that, the iris position, lens haptic position changes, so that it comes more anteriorly. It comes more towards the needle, and it becomes, you have to pull down the needle a lot on the haptics a lot, and so that it may get deformed, or haptics may break also. So it's better to use 2 needles. The problems with the 2 needles is anticipated is slippage of the opposite haptic in the vitreous. This happens in large eyeballs, particularly in myopes. To do away with this or handle this situation, we use a 27 gauge needle and not a 26 gauge needle, so that it has a firmer grip on the haptic, and scleral tunnels created are smaller in size. Another option is to keep one needle in place, as we are showing this haptic in this video. So we are threaded. After threading this, we take out both the needles, but keep one needle at place. Flange one haptic. and then you take out the another needle. This prevents slippage into the vitreous cavity. So pointers for the successful surgery is practice before you do. You have to get the feel of how it goes inside, how much resistance it applies, so that you don't do it inside the eye for the first time. And you have to do the markings meticulously so that the final lens position is well centered. I've already shown these markings. Angulation has to be accounted by while entering the eye. The correct optic position is slightly away from the tip. If you hold too close, it slips out. If you hold it a bit away, it can go easily inside the bore of the haptic. Now, the flange creation, what I've learned after some doing few cases is that you should not touch the tip of the haptic. You should just keep it away, and a radiant heat should melt the haptic and not the touch of the haptic. And you want to create a you have to put the radiant heat. One is the battery operated one, and this is the direct heat operated. And you have to create a flange like this, the first one, the conical one, and not a round one. If you get a round, if you produce a disc at the end, the disc will remain outside the sclera in the subconjunctival space, and that will create a problem of externalization or further problems in the long run. The conical end will go inside the tunnel you have created with the needle and prevent it from the externalization. So the final haptic position is this shown in the AIOCT. You can barely see the haptics in the sclera, fine touch, and they are entirely within the sclera and not in the subconjunctival space. So advantages are reduced surgical time, and there is an advantage of flap, and you can use it in very small pupil also. The flange advantage is that one small video of an animal eye, there's so if you pull the haptic, the optic junction breaks essentially. Even if you pull it, but the haptic doesn't dislodge from the sclera. Stop moving. Can't move. Yeah, he is controlling. It was the last. And the small pupil also you can do this surgery because the optic stretches the pupil, and that allows you to do and you can use your needle to stretch the pupil in the opposite side, so that you can insert it through those very small pupil as well. So many complications can happen as with any other technique. So thank you for your patient listening, and I thank Dr. Manish for inviting me from here and compiling a beautiful collection of the talk speakers. Thank you.
Thank you, Dr. Mandar, for that excellent talk. I think we have few minutes before we give the hall to our next speaker. If there are any questions from the audience. I prefer to do complete vitrectomy for all patients. At least core vitrectomy. If it's a young patient and PVD is not coming easily, I might leave that. But otherwise, I do complete vitrectomy.
Yeah, I agree with the given option. Once I'm in, I would prefer to do complete vitrectomy, except what is a pediatric case, sometimes PVD induction may not be possible. We make an attempt, but if not possible, we leave it some. But given option, the advantage is later on PVD related issues can happen. And most important, when you look at it, the CME in these eyes, incidence is as high almost 43% what is reported. But once you have complete vitrectomy, we hardly see any CME. Yeah, I think he's maybe please come to the.
Sir, actually, I wanted to ask on this only. In pediatric cases, when a PVD is not possible, so what's your approach, sir? Do you do a vitrectomy to a mid-level or do a PVD to the extent possible?
Well, I do when as a VR surgeon, when I'm in, I would prefer to do as much as possible. Just small thin film will have. But yes, we have our anterior segment colleague. When they are having only anterior approach, they are doing. So whatever they do is whatever in the through limbus get whatever vitrectomy they want to. But I somehow always hesitant because haptics going around either side. There's always scope for vitreous getting entangled and later on not only CME, delayed onset retinal tears and coming back with RD. We have faces few cases like this. So as a VR surgeon, given option, I would do complete vitrectomy, especially shaving the vitreous, anterior hyaloid and anterior margin, that area, definitely I want to have absolutely clear thing. Because not only traction, but it sometimes can have a mechanically push the lens to one side, mechanical hindrance will be there. So decentration chances are also more.
Thank you, sir. So all these surgeons I could see were practicing one technique or the other, but most of the times we have lenses which dislocated or subluxated, and we need to refix the same lens. So at that time, which technique will you follow?
I think
all of the doctors can.
Yeah. So basically, it would depend on a lot of factors, whether you have adequate capsular support. Only PC is gone, but rhexis margin is there, and the lens is, if you can do optic capture, even single piece IOL can be re-implanted. 3-piece IOLs, obviously, they are easily re-implanted. 3-piece IOLs, if they are there, you can use any one of the techniques, externalize the haptics and put it back. With the Prolene suture, even the closed loop closed C loop haptics can be used with 4-point fixation. You can do with Prolene, what Dr. Aditya presented. You can get fairly good stabilization with that also.
So I think Canna-Brava is the answer for all these lenses.
For closed loop like Rayner type of lenses, yes, that can be an answer, yes.
I've tried various techniques, most of what have been shown here, but I think Dr. Nivian's lens is probably the least traumatic. But I wanted to ask you the question, sometimes because of the flexibility, it stretches too much and it breaks the haptic, the head. Any specific pointers to how to avoid that?
Yeah, initially when I have faced that, the only two tricks is, yes, once when you grab the lens, I don't pull it because it's a single piece lens, so I wait till I inject the remaining of the lens. And usually at the sclerostomy site is where the tug is. Yes. So initially we used to hold it wherever we want and pull it out, and sometimes it slips back because it's slightly bulkier. So that is why we came out with this head-on technique where you have these forceps. So that way when it comes, these haptics actually bend forward, so that way it is slightly smoother when it comes out of the sclerostomy. And sometimes I used to use any forceps, like, so some of these retina forceps or the forceps are sharper, So you will not notice in other things, but here because of the material it chips it, and later on that edges crack, and then when you're pulling the other side it gives way. So when we took these lenses out and analyzed it, so those were the reasons: the right instrumentation and technique and a small learning curve.
I think the size of the sclerostomy exactly that matters. So
Yeah.
what is the
23 gauge. I just used a 23 gauge needle. Then, yeah.
Which technique is preferable in pediatric patient, because the eye is growing and there might be higher risk of decentrations later on? If there is any lowest age limit to perform SFIL technique?
So actually, I don't think there's a clear answer as to which technique is preferred, because very rightly the eyes are growing on, and both sutured and sutureless have been done. We would usually defer surgery until an age of minimum 7 to 8 years and give the child refractive correction and amblyopia therapy until then. Very rarely we have had occasions when I have done before, like the youngest child I have done is about 3 to 4 years old, who was a congenital cataract, bilaterally aphakic, special needs child who couldn't manage either glasses or contact lenses. And that child I had done sutured SFIL. Otherwise, I do a lot of sutureless nowadays, and most of them, but I would prefer to wait. And we also see a lot of trauma and open globe injuries and a lot of unilateral aphakias in our center. And we are going away with sutureless, and I have been doing them for the past 14-15 years. So far, I have not had a major issue. Sir, do you have anything about growing eyeball?
The same thing, because if we look at it, anatomy and embryology, by age of 4, 96% of the growth of anterior chamber, anterior segment is done. So subsequent growth of posterior chamber. So calculation is more critical, IOL power calculation, than acting IOL technique. So by theoretically speaking, by 4 you can do, but I agree with Dr. Like what she said is generally we prefer definitely below 7 years as far as possible. I also did youngest was 4 years because unilateral aphakia difficult to manage with glasses and contact lenses. So youngest I did 4, but as given option we to avoid definitely till 7 years. But technique wise is not an issue. Issue is IOL power calculation.
I think the technique, the issue more is that the sclera is very soft and pliable. So whichever technique you do, whether you're tucking the haptics or you're doing the sutures, and there's a lot of thick tenons, those are the things which become more challenging in these cases, surgically, when you're actually doing the procedure.
Thank you, sir. My another question is regarding CMT flex lens. Sir, in your design, the optic to haptic ratio is very huge. Like optic is very large, haptic is very small. So have you assessed the long-term stability in terms of rotational stability, particularly in the vertical meridian? Using AIOC or something like that?
Long-term, the rotational stability, because I think once it is fixed, the lens doesn't actually rotate.
Yeah, lens won't move anterior, posterior, but regarding in the vertical meridian, can it move slightly here?
Tilt, he's talking about
tilt of the
tilting.
lens.
Yeah,
Yes,
you are
yes.
talking about tilt. Basically, up to 7 degrees of tilt is acceptable. Okay, so I understand what you mean, particularly when both the haptics slowly start stretching up, the IOL tend to tilt, rotate basically. But up to 7 degrees is acceptable, and I think generally, that's what I said, beyond 7 years of age, generally that stretch is negligible, so chances of tilt are not really that, unless IOL, your location, it's not exactly 180 degree, the entry, particularly when doing MANEESH technique, one goes little bit oblique and one goes different direction, those things, those issues will be there. Otherwise not.
Concludes.
Maybe we should
Time
measure it
over.
in our studies.
To hand over the session to next presenters. Thank you all for attending the session in great numbers, and thank you my co-author. Excellent talks. Thank you so much.
If you really have a photograph.